I'd like to thank you for the opportunity to speak today on minimally invasive repair of rib fractures and thoracic trauma. It's an honor to speak here, and I'm grateful for the opportunity. These are my disclosures, and I will be discussing some of the products for which I'm a consultant. History of rib fixation is quite dark and initially involved primarily traction treatment. And it wasn't until the 1960s that people began to use stabilization techniques, initially with Kirschner wires. These Kirschner wire repairs were then supplemented with plate-style repairs. But the modern era of rib fracture fixation, in my mind, really began in 2002 with the Tanaka trial, which demonstrated superiority of surgical stabilization to pneumatic stabilization among patients with flail chest. And in this regard, I think people began to believe that these big flail-style injuries required a big repair, and patients were often getting quite extensive surgeries to repair quite extensive injuries. More recently, there have been trials to look at outcomes of patients with less severe injuries. The Chest Wall Injury Society non-flail trial was published late in 2019 or early 2020, and was a mixed observational randomized trial of about 110 patients who were evaluated in observational and operative arms. These groups were quite similar and were evaluated at multiple centers. The primary outcome of that trial involved looking at numeric pain scores and demonstrated that surgical stabilization was associated with improvement at 1 week, 2 weeks, 4 weeks, and 8 weeks, and additionally showed decreased narcotic requirements among surgical stabilization patients at 2 weeks and improved respiratory quality of life at 2 weeks. In that style, or in that point of view, other studies have also looked at functional outcomes. This study looked at functional outcomes in patients with rib fractures who were older than 65, and looked at a group of non-operative patients versus patients who received rib plating to compare outcomes such as readmission, pneumonia, pleural effusion, and death. This trial did include patients who had non-flail injuries, and demonstrated really dramatic differences in functional status outcomes. They did note improvement in functional status at 2 weeks, 2 months, and 4 months, and additionally other outcomes such as sleeping and respiratory fatigue out in those durations as well. And in this regard, I think there's been a changing understanding of sort of the purpose of rib fixation. Initially, the rib fracture repair saves lives sort of paradigm was promoted by the Tanaka trial, and then became a part of the East Practice Management Guidelines. And in that regard, rib fracture repair was thought to also reduce post-injury complications. So there was this association of rib fracture repairs and death, and stabilization stopped that. There was then emerging evidence that rib fracture repair improved quality of life, though, and studies such as the paradigm shift study mentioned in the CWIS non-flail trial also have demonstrated that. And in this regard, the sort of new thoughts of rib fixation is that it can help rehabilitate people and be part of a process to reduce pain associated with rib fractures. There are a variety of techniques to do this. This sort of traditional plating systems could involve something as simple as a suture cerclage or an absorbable plate. There are U-style plates which wrap around the rib. There are anterior plates or extrathoracic plates with bicortical and monocortical screws, and Judet struts, which were the subject of the Tanaka trial. But I think we have to appreciate that chest wall surgery is painful, and that pain was potentially proportional not only to the patient's injury, but also in some regards to the extent of surgery performed. There were several strategies to try to reduce the impact of surgery on patients. Parachi in 2018 performed an analysis of the timing of the procedure, which showed that early repair was likely better for both outcomes such as length of stay, but also potentially for outcomes such as surgical complications. Regional anesthesia certainly helps patient-centered outcomes. Epidural is thought to be beneficial, and other regional blocks may also be beneficial. And then there is an opinion that muscle-sparing approaches may be better. There's not much data to support this, and these exposures can be difficult, but it is believed that reduced muscle division can lead to improved functional outcomes. Unfortunately, these exposures limit, to some extent, the locations of fractures that can be approached, and can be difficult to perform, with only 33% of trauma surgeons expressing comfort with these approaches. In other disciplines, however, minimally invasive repairs are associated, minimally invasive surgery is associated with improved outcomes. In lung cancer resection, thoracoscopic lobectomy is less painful than thoracotomy, and it has a faster return to mild pain than thoracotomy. There's also some suggestion that shoulder strength is better after thoracoscopic approaches. In thoracoscopic chest wall resection, this approach has been associated with faster recovery and improved levels of activity and shorter chest tube duration and less hospital stay. And in this regard, I approached my rib fracture fixation with a minimally invasive sort of style. I had been performing a lot of my repairs with so-called extrathoracic fats. Here you can see that I use a rule track and a scapular tractor to elevate the scapula away from the chest wall. And then I use a thoracoscope to visualize the fractures in an extrathoracic plane, and use a right angle screwdriver to affix rib plates. This approach can be associated with excellent cosmetic results and, in my mind, also excellent functional recoveries. Here's another example of the rule track providing exposure to a lateral fracture location, and the thoracoscope, again, visualizing a fracture. This is a 2-fracture repair repaired through a 4-centimeter incision. There is an additional MIS approach to rib trauma, which uses an intrathoracic plate. This plating system was designed or created for an MIS system, and it was used in about 100 cases in 25 hospitals in 2019. This really demonstrates, I think, how new this technology is, and in that regard, much of this is emerging in terms of its utility and its usefulness. The reported advantages of this system include that it could be muscle sparing, and it does not require plate shaping, which may have advantages in terms of surgical duration. Of course, the disadvantages in that it is novel. There is no published results of this system, and it certainly requires thoracoscopic expertise. I've used this technique several times. This is a 99-year-old patient who fell from standing and had isolated rib fractures. She was admitted to an ICU and decompensated. I recommended repair, and she was taken on hospital day 1. Her repair, I think, went well. She had a muscle sparing repair through the auscultatory window. She was discharged on day 3 to a nursing home, and then left that nursing home 4 weeks later for home. I saw her recently doing quite well and living independently. This intrathoracic technique can also be used in hybrid situations. This is a patient with both posterior and lateral fractures. I approached the posterior fractures using a traditional extrathoracic bicortical screw system, and rather than performing a large secondary incision for the lateral fractures, I used an intrathoracic technique to approach those, which again, in this isolated case, I believe was associated with a good outcome. So there are sort of growing data, sort of increasing awareness that the benefit of rib fracture repair is not only a survival or complication benefit, but also a pain and quality of life benefit. And many of these outcomes are particularly important in the old and frail patients. Surgeons, I think, are often uncomfortable with the current exposures and the current extrathoracic approaches. And I really believe some of these minimally invasive techniques can be beneficial both to surgeons and to patients. So as this concept of stabilization sort of expands to broader cohorts, I really advocate new approaches and new perspectives towards fixation. And I recommend or support minimally invasive techniques as an opportunity to disrupt conventional thinking. Really, if we are treating pain and functional recovery, a less invasive approach is appropriate, and an extra or intrathoracic thoracoscopic repair may be ideal for certain patients, especially those patients who have fewer than 3 fractures or are older or obese. With that, I'll conclude these remarks and this video. I'd like to thank you for your attention. And again, thank you for the opportunity to speak today.